Okay, now based on this discussion we have so far, you've seen that hyponatremia can be divided based on ECF, extracellular fluid tonicity, to hypertonic, that the ECF is hypertonic, isotonic, they go hand in hand, hypertonic and isotonic, and hypotonic. And the most common type in clinical practice, the massive majority of cases are hypotonic hyponatremia. So the first step in assessing hyponatremia is deciding which one are you dealing with, the hypertonic, isotonic, or hypotonic hyponatremia. So whenever you get at a sodium level, let's say 120 of sodium concentration, the first question we need to ask is, what's ECF tonicity? What kind of hyponatremia are we dealing with? Hypertonic, hypotonic, or isotonic? You'll notice that here we did not mention pseudo-hyponatremia, which is mainly a lab error for the following reason we mentioned. But I'm going to repeat them here quickly, and I will not mention pseudo-hyponatremia after that. First of all, it's very rare. Second of all, the new lab techniques does not cause that problems. Third of all, it's associated with severe hyperproteinemia, hypertriglyceridemia. So you're looking for plasma cell, anything in the history about plasma cell disorders, any lipemic serum, and I've never seen it in practice, and I think you will only see it in board exam. So 99% you'll be right saying this is not pseudo-hyponatremia nowadays. Okay, I hope you will agree with me. Now, what's the ECF tonicity? The only way to tell is by checking measure osmolality. Now, measure osmolality, we're having a few problems here with it. First of all, it's not always available to check, and it takes sometimes a day or two to come back unless you are lucky and you can get it right away. And the second problem, also, it can be misleading because it includes BUN, and BUN is inactive osmol that does not contribute to tonicity. So you want always to subtract BUN from the measured osmolality. So tonicity technically equal to measured osmolality minus BUN divided by 2.8. That will give you tonicity. So somebody with end-stage renal disease, you will notice, and BUN of 100, you will notice they are hypoosmolar or hypertonic, but they are not. Also, you need to be careful with the presence of ethanol, because these people will have high measured osmolarity compared to calculated osmolality, and then an osmolar gap, but you check they have high ethanol level. Ethanol is similar to BUN, does not contribute to tonicity. So you need to pay attention to that. Now, once you have the measured osmolality after avoiding these inactive solutes, you can compare that to body normal osmolality. If it's bigger than normal osmolality, then this is hypertonic. If it's similar to normal osmolality or close, this is isotonic. And if it's lower than normal osmolality, this is hypotonic, and this is the most common type. So how do we approach this in real life if we don't have the ability to get measured osmolality quickly, right? So sometimes you cannot get it right away. So what do you do? So remember, you get a BMP or CMP that tells you about the sodium. So immediately, once I get that, I looked at the glucose, if it's normal or not. And then I immediately check corrected sodium. Because if the glucose is elevated, and when I correct the sodium goes back to normal, then mainly I'm dealing with hypertonic hyponatremia from hyperglycemia. Example to make it clear. If you have a blood sugar of 1,000, based on that, I mean, there is 900 above 100, so 900 by 1.6, that's almost 14.4 milli equivalent. The sodium should be lower than normal. So if the sodium 120, You add this 14.4, then the sodium will be around 31, 34, 130, which is pretty normal. So you can say this is purely related to hypertonic hyponatremia from hyperglycemia, without really needing to measure the osmolality or check measured osmolality. Now, most often you will see that this number, that the sodium is even lower, because most of the time there is more than one element causing the hyponatremia. For example, you have hyperglycemia and you have volume depletion on top of that, so you need to pay attention to that. Next questions: is there anything that would make you think or make us think of hypertonic hyponatremia? Okay, so I would think of the condition that would cause hypertonic hyponatremia and rule them out in history. Is the patient receiving IVIG? Why? Because IVIG mixed with mannitol. Is the patient receiving mannitol? Did the patient has recently a prostate or uterine surgery? Because they use hypertonic solution during this surgery and they can be reabsorbed in the body. So if there is any of these factors and you still think of hypertonic hyponatremia, then there is no escape. We have to check measure osmolality to get a better idea. Okay, if none of these, and then the lower sodium not explained by glucose, then we have to move to the next step. Now we can safely say, without measuring the osmolality, that there is no need, because there is nothing really to indicate that this patient having hypertonic hyponatremia. So and it's very unlikely pseudo hyponatremia. So we can safely say we're dealing now with hypotonic hyponatremia. Okay. Now, if you got the measure osmolality will tell us now we have a clear idea we're dealing with hypertonic or hypotonic. Hypotonic hyponatremia is the most common reason or cause of hyponatremia in clinical practice. So let's open a new page here. Okay, now hypotonic hyponatremia, which is the most commonly problem we're going to encounter. We said we reached here after we said it's not pseudo hyponatremia as we talked, and it's not hypertonic hyponatremia based on measured osmolality. The corrected one for BUN as we said, and ethanol if needed. It's hard to correct for ethanol, but the fact that ethanol presence may increase the measured osmolality along with the BUN, and they may create that feeling that we're dealing with isotonic or hypertonic hyponatremia. But when you correct it for both, usually we are dealing with hypotonic hyponatremia. And the other way we said, if you don't have measured osmolality, is we ruled out this after ruling out that hyperglycemia is not the cause for that. And this is because the patient was euglycemic, or after we corrected sodium for hypoglycemia, it was lower than what's supposed to be, indicating there is an additional problem to hyperglycemia. And after lack of history that suggests the possibility of hypertonic hyponatremia. And we mentioned just those: the mannitol, IVIG, prostate, and uterine surgery. Now, based on this, now we are dealing with hypotonic hyponatremia. Hypotonic hyponatremia always involve two problems: continuing water intake, and this could be orally, or could be somebody in the hospital receiving hypotonic solutions, IV, plus inability to excrete excess water. So there is excess water because the patient was likely still receiving some water or some hypotonic solution and unable to excrete excess water. Okay. The first step, once you say this is hypotonic hyponatremia, the first question is, what's the GFR? And this is very easy. You look at the BMP and look at their kidney function. Is it severely diminished? Are they in end-stage renal disease, on dialysis, or close to being dialysis advanced CKD? If that's the case, then you are dealing with hypotonic hyponatremia related to this, because those people unable to produce urine, unable to get rid of excess water and having diluted urine. So any amount of water they drink will result in hyponatremia. If their kidney function is good, the next questions, are they receiving any thiazides, diuretics? This is before you do anything else. You ask these two questions. If kidney function is okay, are they on thiazide? If they are, mainly HCTZ, mainly elderly, then this is the culprit of hyponatremia until proven otherwise. Mainly in elderly and happens in the first few weeks, could have a late onset as well. And what happened here is they continue to have water intake, as we just said, plus impaired diluted urine. So they are not volume depleted, they're not over diuresing. So these patients are euvolemic. Now, the patient kidney function is okay. The patient is not on thiazide diuretics. Now I come to the next stage of hypotonic hyponatremia. Let me open a new slide for that. Now we reach this stage. Now it's time to assess volume status. Now it's time to say, is the patient hypervolemic? So this applies only when we reach the hypotonic after ruling out intestinal disease, thiazide diuretics, hypovolemic, and euvolemic. Okay. Hypervolemic, it's pretty obvious, should be pretty obvious. You see signs of volume overload. Okay. And here you see signs of volume depletion. Both here, peripheral edema, JVD, ascites, mainly in heart failure and cirrhosis. It's not much prominent for some reason in nephrotic syndrome. And here you could have renal or extra-renal losses. When I say renal, mainly I'm talking about overdiuresis, specifically furosemide, cerebral salt wasting, adrenal insufficiency can make you lose volume renally by producing too much urine, right? And solutes in the urine. Now, both will lead to decrease in effective circulatory volume in the intravascular pressure, right? Let me just delete here now, just delete this so I can have space for now. This will lead to activation of baroreceptors and activation release of ADH. So what happened? Two things will happen. So the ADH will retain water on the collecting duct, and on proximal tubules the body will absorb more sodium and H2O. So we're having reabsorption of sodium and water much more than normal in proximal tubules because of the decreased effective circulatory volume, and we have activation of the ADH. So we're retaining water and sodium, but much more water than sodium. That will lead to the urine sodium will be low because most of it being absorbed on the proximal tubules, and low less than 10 milliequivalent or 20. There is one exception in vomiting. This exception for vomiting, we'll come to vomiting later. Vomiting can produce metabolic alkalosis. So the body, to counteract metabolic alkalosis, need to get rid of bicarb and sometimes spill sodium out with the bicarb, leading to higher urine sodium in vomiting cases. How about urine osmolality? As you can guess, the ADH will try to produce concentrated urine, so it will be high because we're trying to give concentrated urine. Okay, so that's when we have two obvious cases: volume overload or volume depletion. Volume depletion, patient looking dry, hypotensive, tachycardia or having orthostatic hypotension, and have a clear source of volume loss, which include vomiting, as extrarenal include vomiting, diarrhea, third spacing with different, like let's say somebody with severe pancreatitis, severe inflammatory syndrome, septic shock, burns, bleeding, all these things that can make you lose volume. Now, if things not clear and should be clear, and are you dealing with renal losses, change the color here, renal losses or extrarenal losses, GI, how do you differentiate? Again, the urine sodium here, we said in both will be low. This is accurate for the hypervolemic, for the heart failure, liver cirrhosis, and for extrarenal losses. For renal losses, urine, sodium, and chloride will be high, usually above, I think, 40. And that's when you start thinking of, is this secondary to furosemide, over diuresis from furosemide, cerebral salt wasting, adrenal insufficiency can cause that. Here, we mentioned that with vomiting, the sodium can be higher because of the metabolic alkalosis, and it can be deceiving because the sodium being spilled with the bicarb. That's why we need to measure also chloride always, because both will be low. In the case of vomiting, the chloride will remain low, so we will not be deceived if the sodium was a little bit high. Let's move now to the case where it's more challenging, where you don't know if the patient is hypovolemic or euvolemic. Based on the history and physical exam, you cannot tell the difference. So that's when you decide, okay, let me check urine osmolality plus urine sodium. If urine osmolality, let's go UO, less than 100 millismol, which means it's almost maximally diluted urine, okay, then I have two things to think of here. This is maximal diluted urine. This could be, as we talked, to excessive water drinking, okay, or low solute consumption or load. Here we said this could be psychogenic polydipsia. It could be also secondary to ecstasy, ingestion. And here we said tea and toast syndrome and beer hypotomania. And we explain why this happened in those cases. So the urine will be maximally diluted, as you could expect in both. We differentiate between them based on the history here. And if you want to diagnose, here you check the daily solute, the total solutes in the urine over 24 hours, and check that how much, and simply fix it by adjusting their diet, and here by discontinuing alcohol drinking, hopefully preferably gradually. Now, as I said, in clinical practice, this is rarely can lead to hyponatremia by itself unless you're drinking a massive amount of water, but usually it leads to hyponatremia if something else going on that led to retention of water, something that led to release of ADH. Medications, and especially antipsychotics, can lead to that. Now, you need to pay attention, because was this urine osmolality obtained after giving this patient some volume, some normal saline? Because this is what happens when you have volume depletion and you give normal saline. Now you switch off, you're correcting that volume, the baroreceptors will feel there is enough pressure now, switch off the ADH, and the ADH now will allow the urine to be diluted. So that means the patient is recovering and improving, and from volume depletion rather than one of these conditions. That's why it's important to check if the patient received any fluids. Now, the other thing we need to check here, if the urine osmolality is not, or the urine is not maximally diluted, so what's possibly have happened here? And that's here where we check urine sodium. Urine NA here, if the urine is not maximally diluted, will help us figure out what's going on. How? If urine sodium here, we reach this status, you checked urine sodium, the urine osmolality was higher than 100, you checked urine sodium, if it's more than 40 milliequivalent, okay, then, so urine osmolality above 100 and sodium more than 40 milliequivalent, then rule out adrenal insufficiency, rule out hypothyroidism, and if they both being ruled out, then think of syndrome of inappropriate ADH. See, we reach this syndrome of inappropriate ADH after going through how many steps? So it's not something you jump right on. Now, if the sodium of urine was less than 40, then most likely we're dealing with hypovolemic hyponatremia. And the trick here to confirm is give normal saline fluids, IV fluid, isotonic IV fluid, and recheck. If it's hypovolemia, usually the urine sodium will remain less than 40, but the urine osmolality will become less than 100. The urine will become diluted. As we explain here, we said when you have hypovolemia, the urine try to be concentrated with low sodium. You give fluid, correct that, the ADH switched off, and now the sodium remain low, but the urine now become more diluted. So that's how we approach hypovolemic or difficult to catch if it's hypovolemia or euvolemia. Next, we'll start talking or digging more into treatment of hyponatremia.